Welcome everybody, and we will be moving on with our discussion for today, that is delirium. I shall just try to share my screen. Yes, you can see the screen, right?
Yes, ma'am, we can.
Yes.
Yeah. Speaking of delirium, I'm sure all of us have seen patients uh, in probably in different settings. Maybe it must be at home, or maybe it must be in the emergency department, maybe it is in your own OP clinic, or maybe it is in ICUs. And I think out of all these places, I think ICU is one place where we see most often. So today's session, we will be going through different aspects of delirium as into how to identify. Are we actually looking at delirium or is it something else? And how to assess it once we do identify it. There are some ways to assess it, some tools to assess it. And after having assessed it and scoring it, now how can you manage it? So these are all the different areas that we are going to be looking at. Before I start off with, I would like to share this clinical scenario with you all. And I would like to have this clinical scenario to be kept in your mind. We will come back to it by the end of the session today, after having discussed a couple of things of all that we have intended to discuss for today. So this is about Ramu, who is a 77-year-old frail gentleman. He has multiple morbidities, like he's a diabetic on medications, he's a hypertensive on medications, he's even having an amputated diabetic foot, and he's on a couple of medications for pain as well for that. And now he's being brought in a wheelchair into the emergency department with features of pneumonia. He is found to be drowsy and disoriented. Now, what are the thoughts that come into your mind? What could be the reason, and how would you be planning to investigate or manage it? We will come back to it. Before that, let us just get to know what is delirium. This is a basic definition of delirium that is given in pretty much all the medical textbooks. They define it as a transient organic brain syndrome characterized by acute onset of disordered attention and cognition, accompanied by disturbance of cognition, psychomotor behavior, and perception. In simple terms, I would like to say delirium is an acute confusional state of the mind. It can be because of toxic or metabolic encephalopathy. Most often, we mistake delirium with something which is quite similar, dementia. So it is important to know, are we looking at delirium or are we looking at dementia? Now, what is it that will help us differentiate the two? Dementia means mainly something which affects the memory, and it is typically caused by anatomic changes in the brain. Generally, we see atrophy of the brain matter. So, and it is more slower in onset. Earlier, we had the definition of delirium telling us that it is acute in onset. In dementia, it's a much slower in onset. And delirium, again, it is often reversible. It may be caused by drug toxicities or other life-threatening conditions. Here, in dementia, is generally permanent and irreversible. This is a table defining the two differences between delirium and dementia, it is quite important to know the differences because you need to know whether you are on the right path. Because if you think that your patient is having dementia and you might just miss out on treating the reversible causes for delirium, and you might miss out on improving the symptom of the patient. So, delirium, like I said before, it is sudden in onset. Dementia is more slow and gradual. Delirium it happens between days to weeks, and in dementia, it is rather permanent. The cause of delirium is probably infections, dehydration, drugs that could probably be causing it. Whereas in dementia, it's more of a chronic brain disorder. You might see it in cases like Alzheimer's disease or dementia with Lewy bodies, vascular dementia. These are all the different kind of dementias that we have learned about. Now, like I said before, it is reversible, and generally, a delirium is seen worst at night. It's something like there's a term called for that. Are you familiar with the term, what it is called? That how the symptoms are worse at night?
Sundowning effect.
Exactly, that's what it is. The sundowning effect, where all the symptoms are worse towards the evening. So that is usually seen, and sometimes it is difficult to differentiate between delirium and dementia in sundowning effect. And attention, cognition, all these are more impaired in delirium. And sometimes there is disorientation to time and place in both scenarios. Even language, memory, there might be some changes in both of them. Now, in delirium, what I would like to again and again and again stress is that delirium is something which requires immediate attention. Something correctable over here, and we need to find the cause and correct it accordingly. So, now coming on to a little discussion. So what what are the different symptoms that you have come across in patients with delirium? This is a free discussion time. Just put in your thoughts. What are the different kind of symptoms that you have seen in patients with delirium?
Patients will be agitated.
Yes, agitation.
Confused. And
confused.
What else? That's it.
Violent. Sounds violent, yeah.
Angry patients.
Yeah, angry.
Any more? Any more? Is it just anger?
Is it just?
Is it just anger and aggression?
Patient
will have very talkative also sometimes, right?
Yeah, right. Talkative.
Yeah. Yeah. So there are certain criteria with which we can define delirium. That is the DSM-4 criteria. And there are 4 points. That is disturbance in consciousness with reduced ability to focus, sustain, and shift attention. There may be a change in cognition as in terms of memory deficit, disorientation, language disturbances, perception disturbances not better explained by a pre-existing stabilized or evolving dementia. Disturbances develops over a short period of time and tends to fluctuate during the course of the day. And there is also clear-cut evidence from history, physical examination, or lab findings that the disturbance is caused by direct physiological consequences of a general medical condition. So, like we were giving like you were putting in some points into the symptoms, Restlessness is definitely one of the most prominent things that we see. Anxiety, irritability, angry, depression, and these patients are more emotionally labile. These are all the symptoms that we usually see in patients with delirium. And very indicative of these symptoms, I would say, is sleeplessness at night, and they are more awake during the day. There are mood personality changes. There could be hallucinations. So these are all more indicative of delirium, I would say. Sometimes you might also see neurological changes in these patients, like if it is associated with some diffuse brain dysfunctions, patients might have some multifocal myoclonus or asterixis, or if the patient is having alcohol withdrawal, the patients might have tremors, or if it is because of opioid toxicity or anticholinergic toxicity, patients could have changes like meiosis or mydriasis, which could be pointing towards the cause for the delirium. And that is something that we should not be missing, which tells us that how physical examination is so very important. So sepsis, hypoxemia, all these conditions can also manifest as tachypnea as in these patients. So that can also give us some idea as to what the diagnosis is. So like I said before, this is just a study where you can actually see that many of these patients, they might not actually have a pre-existing psychotic mood disorder or anxiety or dementia. It could be sometimes the hospitalization per se. It's after hospitalization that many of these patients delirium study. And that is quite interesting. It is something as if it is iatrogenic induced over there, something that has triggered these patients to cause the delirium. So, like the different symptoms that we have been talking about, like you were telling that the patient could be aggressive, angry. I told he could be talkative. I mean, these are all under which delirium would that fit in? I have said that I have put in a chart here saying that there are 3 types of delirium here, as you can see. That would be falling under hypo or hyper or mixed type.
Hyper.
Hyper. Yeah. So that would be falling under hyperactive. Say suppose like Ramu, that example that we were talking about. He was drowsy, he was disoriented. Now he is not angry, he was not shouting or aggressive, but yet he is delirious. He was in hypoactive delirium. So you can also have hyperactive delirium, hypoactive, or sometimes even mixed types of delirium. Most often we tend to mistake hypoactive delirium because we often think that only patients who are the so-called violent, they are termed as delirium. So it is important to also see the other side of it. So what are the risk factors? There is a baseline vulnerability that we say for patients. And there can be precipitating factors also, such as some nauseous stimuli that can actually induce this delirium. So what do you mean by baseline vulnerability of patients? What category of patients would we be referring to? What is making these patients vulnerable for delirium? Any suggestions? Which kind of patients are more vulnerable for delirium otherwise?
Children.
Children?
Older person,
Personality.
type A personality like that.
Yes, probably having some underlying behavior.
Anxiety problems.
Yes, with some baseline psychological issues. In hospitals, usually we see most in
ICU patients. So
ICU patients. Yes, with a sudden change of environment. What is the age generally that we see besides children?
older age group as
Old
well as
age group, yes, the elderly, right? The elderly, more frail, those with a lot of multiple comorbidities. Sometimes it is even seen that it is more prevalent in those with visual impairment and more those who are having more of dehydration, things like that. So we have a vulnerable population who are at higher risk. So it is very important to actually identify these patients pre-hand itself when they come to the hospital so that we can identify the risk factors and modify these risk factors so that they don't go into complete delirium. Okay, I will come back to this point later. I will be elaborating on this point later. Just suggested that, just put a word about that right now because this has come here. So we were talking about the different causes of delirium. Yeah, maybe I should just keep the slide here and, we should just get some points from everybody. What are the different causes for delirium? So what are the different causes for delirium? It can be anything. You can just share, this is no assessment here. This is just free
serious
communication.
infection, sepsis.
Infection, sepsis, yes. Many times like sepsis, like urosepsis, we have seen elderly patients coming with no fever, no urinary symptoms. It's just probably some vomiting and, this frank delirium. So definitely sepsis, one of them. Another?
Electrolyte imbalance.
Electrolyte imbalance.
Like which electrolyte imbalances?
Hyponatremia.
Hyponatremia. Any more? Calcium? Have you seen patients with hypercalcemia?
No.
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 Yeah. Also, they also cause, some delirium in hypercalcemia. And other metabolic causes?
Diabetes, hyperglycemic or hypoglycemic.
Definitely hyperglycemia and hypoglycemia.
Uremic encephalopathies.
Uremic encephalopathy, hepatic encephalopathy. We do see sometimes our elderly patients, most of them at home, sometimes when we go for our home visits, sometimes they present with, they go to the house, the family notices that wait, uh, he has been very angry, he has been sometimes talking things.
Just a
And
minute,
sometimes we
Vineetha.
try to bring it, uh, try to dig down the cause of it. And sometimes it must be something just like, some medications that the patient is taking, or it can be some, like you said, some underlying infections. The patient probably had a catheter, or even hepatic encephalopathy situations where sometimes the patient has had a prolonged constipation. There is a high rise in ammonia levels that also can cause, right? So now let's go back to that big long list. So here, this is a table that is just taken out from the Oxford textbook of palliative medicine. So these show the different factors responsible for delirium. There are CNS tumors, there are secondary causes, a meningeal metastasis, non-metastatic causes like we just discussed, metabolic causes, electrolyte imbalances, glucose abnormalities, infections. We've got pretty much all of it, right, in our discussion. Then hematological abnormalities, nutritional deficiencies like thiamine, folic acid, vitamin B12 deficiencies, vasculitis, paraneoplastic neurological syndromes. So before we go on to of anti-neoplastic therapies, I would like to share an example that for one of these reasons. I want to tell you. I want you to tell me what could it be. Okay. So there is this one patient who was brought into the hematology department, and he was being investigated for low hemoglobin and pretty much MDS-like features. Okay, so everybody is busy doing his bone marrow and things like that. You know, whole array of tests. And this patient is he's a little different from everybody. He's got a big Rudraksha, and so we were just asking the family about. Well, the family was completely not like him. So we were just asking the family how long has he been quite different from his usual routines and things like that. So the family tells that been about 5 years now. He has been a total vegetarian, and he has very strict diet routines that he follows. And of late, there have been some massive behavioral changes also. And this basically the patient was having some behavioral disturbances, and we just discussed about one of the reasons over here. Can you tell me what it could have been? I gave you a clue here, the story.
Vitamin B12 deficiency.
Vitamin B12 deficiency. We got the bloods checked. There was megaloblastic changes that were seen. We got vitamin B12 levels, and it was very low. We started supplementing the patient with thiamine, and there was just a drastic change in the patient. So it just reminded me as I was reading through this, I thought I'll just share with you all. So again, there are some chemotherapeutic drugs which could also manifest as delirium. I think a personal experience I think I've had is alpha interferon therapy that was used for one of the patients did precipitate some psychiatrical kind of manifestations. So I remember we used to send the patient to psychiatry before we started the treatment so that we could get a clearance from there. So that is also one more that I would like to add in this list. Then radiation to the brain, it can cause acute or delayed encephalopathy. Toxicity of other drugs like anticholinergics, belladonna alkaloids, scopolamine, atropine, hyoscine. There are also other drugs with anticholinergic activity like tricyclic antidepressants, diphenhydramine, chlorpromazine, hyoscine butyl bromide. Now, some drugs like anxiolytics, hypnotics, or even some drugs like steroids can cause such delirium in patients. I remember we had a patient with multiple myeloma. It was a very quite elderly, frail lady who was started on treatment with high dose pulse. Then it was not pulse dexamethasone. It was high dose of dexamethasone for 4 days continuously. And the patient was also put on lenalidomide. So the first day we started the drug. The next day morning when we went for rounds, we heard that all night the patient had been up And by morning, the patient had actually got delirious and was talking very loudly and at a very high pitched tone and irrelevant talk. We just could not understand what it was. And finally, when we actually got down to her chart, her drug chart, it struck us that it's probably the steroids, the dexamethasone that was making her delirious, and we had to cut it down. And definitely, she improved with that. Now, opioids. Opioids, you must have had your class on opioids, the first few classes on pain and some amount of confusion or hallucination are sometimes seen in some patients. Usually, we don't see these kind of delirium episodes in patients with severe pain. Because the opioid receptors are all open, there is a less chance for side effects in such patients. But sometimes in some patients, it can precipitate. And either we try to bring down the dose of the opioid in such situations, or generally it just wears off in 2 days. That's what is usually seen. So we just give some medications to tide over that time, and then the patient is fine after that. Sometimes these symptoms might persist, and we might have to go for a opioid rotation altogether. So opioids is one of the drugs, and again, I have given a couple of other drugs also over here. Some other diseases like CNS diseases, cardiac diseases, lung diseases, endocrinopathies, all can be causative factors. So this is just another study which was done by Tuma R, and he studied 140 patients with delirium and found that only 31% of those patients had one single cause. So the rest of the 69 patients had multiple causes for delirium. So as you can see, when you are evaluating your patients with delirium, it's almost mandatory that you have that entire checklist in your mind. That same points that we saw before. It's almost like a checklist you need to have in your mind, and you have to go through each and every point because now we know that delirium can be multifactorial. So it's almost like you have to see whether does this patient have electrolyte imbalance, how many drugs is this patient on, is this patient dehydrated, are there any signs of encephalopathy? All these have to be looked into. So now how do you assess these patients? A brief history taking, maybe not, a more elaborate history taking would be what I would prefer. You need to know how exactly when did the delirium start. It might not be just from the point of admission. You might need to know what was the normal for the patient and how long has the patient been having these disorientation and irrelevant talk, and what was the event that happened, if at all, that precipitated this at home. So it is equally important to know what was happening, or has there been similar episodes in the past. So other than history taking, physical examination and neurological examination is also very important. Physical examination, we had talked about how, in some neurological situations or some drug toxicities, how it can, even examination of the pupils can show constriction of the pupils or mydriasis. What could it be pointing towards? Or you are seeing some deficits, some neurological deficits. Is it just metabolic that we are looking at, or is there more something organic behind it? Or it could be your chest findings. The chest findings, is it pointing out towards some infection? So there are a lot of things that we have to look into physical examination in delirium. And then we go on to assessment tools. Are you all familiar with assessment tools for delirium, like one or two that you have heard of? Anybody?
No, 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 no.
Have you heard MMSC, CAM? These are all the short forms.
No, no, no. We are not familiar with this.
Okay. This is the assessment tools that is generally used. This is basically based on the cognitive function and performance. Okay, so that MMSE that I was talking about, that is a mini mental state examination, and then you have another one, confusion assessment method. So these two tools, they are not diagnostic of delirium, okay, but they might help to make you understand if the patient is having a significant cognitive failure. Now, delirium rating scale and memorial delirium assessment scale, they helped to understand the severity of the delirium. Now, these scales are more sensitive, is highly sensitive and highly specific, and they are more diagnostic of delirium. Okay, I have just attached a copy of that, how it looks. So this is the MMSC chart, and this is how it looks. So basically what you do is you ask for questions and you give a score and you total the score, and that is how it is evaluated. And on the other side, you have the other one, the CAM. Sorry, you have the CAM. And this requires a little professional trained person to fill in this. This also helps to identify for significant cognitive failure in the patient. Now, this is the delirium rating scale that I was telling you about. It helps to understand the severity of the delirium, and it is more diagnostic. Now, EEGs also have a role in understanding delirium. It is seen that EEGs are notably, there is some symmetrical slowing, and there is a reduction in the alpha rhythm and increase in delta and theta frequency. So sometimes if the patient is very hyperactive delirium, there may be more of a fast wave and beta activity also that is seen. And apparently EEGs also help in identifying non-convulsive epilepsies from delirium that could be seen in metabolic or sometimes even chemotherapy-induced conditions like ifosfamide therapy-induced situations. Okay. Now, you all had talked about, it could be infection. One of the causes can be infection, or it can be, glucose impairments or things like that. So what are the tests that we do? So the tests are, if you suspect infection, you can go for temperature or blood cultures, urine cultures, or even throat cultures, sputum cultures. Then others like urine analysis, common blood count, which will tell you if the patient is having sepsis. And also acid-base balance issues can also precipitate delirium. A good ABG will also tell you quite a bit. Electrolyte imbalances, like somebody was rightly mentioning, sodium, hyponatremia, all that can also cause. Renal failure, urea, creatinine, all that also has to be looked into. Liver failure, liver function test, ammonia, and DIC screening, coagulation profiles are also important. Any bleed, high chance for bleed, could it have led to a CNS bleed causing this? that also should be looked into. CSF cytology, it can also, sometimes a patient might be just showing up with changes in behavior, and we are trying to rule out all infections. There is no infection that we have been able to pinpoint, and sometimes CSF analysis might just bring out the cause. We might see malignant cells sometimes in the CSF, or we might just see some other factors which are more pointing towards an indolent infection. So that again. And also we have the imaging like the CT and the MRI, which will give us more higher information. Now, autoantibodies like anti-WHO, that is all higher investigations that generally we don't usually do, especially in palliative care. It's not, it's above what we usually do. So, and then again, like we were discussing before, B12 levels, even thyroid hormones, any disturbances in the thyroid hormone, thyrotoxicosis. Thyrotoxicosis can also present with behavioral symptoms. So these are all the different investigations that we have to basically look into before we can actually point out what is the cause for delirium. There was this one patient who was in my ward under treatment for CA lung. Okay, and this patient was a very good patient and a very nice family man. And we started the treatment for him, and day by day, the wife was coming up to us and telling us that, I don't understand what it is. He's very angry. I think it is the diagnosis that, he is not able to take it. So he is just showing anger to us. He's never been this angry. He's never talked to us like this before. And day by day, his behavior kept changing. And we were not able to understand. We just thought it was an adjustment disorder. It was just something that he could not cope up with. He just came to know he had cancer. And one day, in the morning when we went, we came to hear that the patient ran out of his bed, above his bed rails. He just ran out of his bed and ran out to the veranda of the ward. And it took 2-3 people to actually get him back to the room. He was completely delirious, and they had to use medications to bring him to calm down. So it just kept worsening day by day, and he was completely on chemical and physical restraints. Now, on the third day after this event, the son came to us and told, what, I just want to take him home, and please allow me to do that. He is just so very upset. Let he just be home for one day and I will bring him back. So we also thought, okay, we shall respect his choice and we shall send him home. You won't believe it. They went home the very next day, not even exaggerating, the very next day in the afternoon, late afternoon, the son calls up to the OPD and he's like, oh, my father, he's completely fine now. And we were like, how did that happen? I mean, that's a miracle. How, what is the change that happened there? So the son was like, well, after coming home, my father, he just started smoking again and everything was fine. The delirium that we were seeing was a nicotine withdrawal. So I think the list is way too big it's a whole big list that we need to have. It's not as simple as you see a patient with the delirium and the first thing that comes to your mind is that, oh, this patient is very aggressive. Let us give Serenase and Phenergan. That is the usual kind of thought that comes to everybody's mind, isn't it? So now, what are the risks involved in delirium? It is said that patients with delirium apparently have a risk 6 times higher risk for falls. So, like you know, if especially elderly patients, if they have falls, they develop fractures, bruising, bleeding. All this again increases the length of hospitalization and morbidity, and also finally increases the mortality of this group of patients, isn't it? So it also brings about, delirium also brings about functional decline of such patients. Their quality of life is zero. So basically, there is a huge function decline in such patients. And such patients may also need physical and chemical restraint. So I want your thoughts on that, what do you think about physical and chemical restraint? Anybody can answer. What do you think about physical and chemical restraint? How much of physical restraint and how much of chemical restraint should we be applying for patients? I'm sure everybody has seen patients with hands tied down and
Yes.
all that. Yeah. So how is the family taking it when you see that?
Physical restraint to the no idea.
Is the patient liking it?
No, patient won't be liking that.
Patient won't be liking it. Does the family like it?
No.
The family can't see it either.
Stay there. Yeah.
It's very painful to see. As it is, the family is devastated seeing that their loved one is a totally new character on its own. So then having to see the patient tied down, the loved one tied down, hands and legs, that itself is painful, isn't it?
Yes.
And many a times, sometimes they try to yank the hand and leg, they get bruises. That is also seen. We have all seen skin peelings, isn't it? I can see only Anand talking here. Let's make it a free discussion. There is nothing like assessment or anything here. This is for us just to discuss. This is just a platform for us to discuss on the topic. So you may need to think about physical and chemical restraints for such patients. We will come more on to that when we come to the treatment part. Failure to maintain adequate hydration can also make it risky, and delirium causes prolonged hospital stay or might even be a reason for death. So this is what we were talking about. Tying down the patient, literally, isn't it? So treatment. How will you treat delirium? How have you seen delirium being treated? Medicines? Drugs? Which one?
Delirium.
Mainly drugs.
Mainly drugs,
Yeah.
right? Which drugs are commonly used? Which are the common drugs that you have seen being used?
Delirium.
Olanzapine.
Olanzapine, yes. Also favorite nowadays. And it does work. It's very effective. What else? Any other drug? Other than olanzapine?
Risperidone might be.
Risperidone?
Yeah.
Yes, risperidone can also be used. What else? What do we give as IV?
Give haloperidol.
Haloperidol. That is definitely our first drug of choice. Okay.
Okay.
So, like you all have suggested, olanzapine, risperidone, all these are also very effective. But I would always like to highlight the fact that haloperidol has always been the best drug of choice. Okay, so haloperidol can be given orally, it can be given as IV, and yeah, we'll get back to that. Now we are going to go into the drug management. So treatment, I would also like to give some importance that prevention by early identification is more important than treating delirium. So you don't wait actually for the patient to get completely delirious and things to get off hand. We try to identify these patients pre-hand itself. So how do you assess these patients? How do you know who is at risk? This is not just one person's assessment. It is basically by a multidisciplinary team. So maybe the physician who is looking at the patient might say that, okay, this patient has come here multiple times with history of delirium. And then the nurse tells that, yeah, actually he's not been sleeping at night for the past 2 days. So that itself is again an indication, okay, this patient is slowly going into delirium. Now the clinical pharmacist who is working in your team tells that, okay, this patient actually is having a whole lot of drugs. And there are multiple opioids also in that. There are some anticholinergics also in that. So it is a collective kind of assessment that we get through the team that helps us to identify these kind of patients. So once you identify these patients, what do? We try to make them as comfortable as possible. We try to make them in a very comfortable environment. We try to surround them with people who they are familiar with.
Okay.
Especially if this patient has an option to be treated in the ICU, we try to manage the patient as much as possible in the room side, and only if highly required, we change the patient to the ICU. Or if the patient has to be given some pain analgesics for a minor surgery or something like that, for a procedure or something like that, we may try to use more of non-opioids rather than opioids, if that gives him adequate analgesia. Otherwise, we have to go the other way. So I would like to highlight that fact here. So if you can prevent delirium, that is what you have to emphasize on. Now, also principles of treatment revolve around correct the correctable, modifying the risk factors, and symptomatic management with non-pharmacological and pharmacological therapies. So we just went through what are the pharmacological therapies used for delirium. Now, there is something that I've written here, non-pharmacological therapies. Now, what do you think is a non-pharmacological site of delirium? Non-pharmacological side of delirium treatment. Any suggestion?
Adequate lighting.
Adequate light? Yes.
And placing a clock in the ICU in the case of
Very
ICU.
good. Correct. So that the patient is oriented to time, right?
Oriented to time, yeah.
Yes.
And make arrangements to meet with their relatives or kin.
Exactly. Exactly. I think one of the major reasons in ICU what happens is that it's a whole lot of tubes and beeping sounds and unfamiliar people, all this which trigger. They are all nauseous stimulus that make the vulnerable patient develop delirium. Right. So, environmental interventions like systematic reorientation and risk modifying protocols, calm, quiet environment. Too much loud noise is not good for such patients. Good light, like you said, facing clocks, calendars, very important. Well-known objects from home can also be very helpful. Maybe if the patient had, a jug always next to his bedside that he always uses at home, and if that jug can be brought to the hospital and kept next to his bedside, or some other object which he can relate to. So these things also make a big difference. Okay, family members, like you just discussed about, all these can also make a huge impact. Now, communication with patient and family. Okay, now communication with family is very important for delirium because the family is completely devastated seeing the patient talking abnormally, and it requires more sittings with the patient family to understand what is happening. We might have to tell this is the reasons probably that there is brain changes. And sometimes they tend to think that the delirium is the end event. They think that the patient is dying, or and they might say that okay, no need to treat anymore. I think he's just suffering too much. They don't realize that it is probably something reversible. Or on the other hand, a total flip can also happen. They might say that it is probably a terminal delirium, but they say that please do everything possible. So you have to actually sit down with the family, let them know what is exactly happening. Or they might just try to blame you. They might say, you have given the patient you have given my father or mother, some medicine yesterday, which has caused this. So communication is very important. Communicate on the condition, the causes, potential for reversibility, role of therapies, and the short-term prognosis. Okay. Now, goals of care has to be planned. Caregiver distress has to be addressed. And patient communication. How do you think we can communicate with the patient? Or do we communicate with the patient? Anybody? Do we talk to the patient? Do we talk to the patient?
We should
Yeah,
make
we
effort.
should.
Do you think we should be talking to the patient? He's delirious.
Yeah, we should.
Try to make him understand, like giving him some instruction that he could follow, like by expressing with a calm voice, or making giving him instruction like one at a time, like that kind of thing. Yeah.
Okay, you would like to give him instructions and maintain that doctor-patient relationship with him. Okay,
Yeah.
that's very nice. Would you also like to pacify him? He must be also worried. Something is going wrong with me.
Yeah.
You might also like to give him a hint that we are looking into it. You're going to feel fine better. You're going to feel better very soon.
Yeah.
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 A lot of non-verbal communication also plays a huge role at this point of time. Maybe, a long set of conversations, he might not be able to register it, but non-verbals also play a very huge role at this point. Therapy, if the patient is alert and is not, too moribund, you can start off with oral therapies. Haloperidol for some mild delirium, it can be started as a small dose of even 0.5 milligram or 0.75 milligram and can be repeated every 8 or 12 hourly. Or you can keep increasing the dose as subcutaneous or IV from 0.5 to 5 milligram and titrate it with infusion, continuous infusion if required, if the patient is extremely delirious. Olanzapine, as suggested, definitely is another drug of choice. 5 milligram can be given 4 times a day, or it can be titrated accordingly. Lorazepam, also another short-acting benzodiazepine. It can help to calm down the patient, but remember, benzodiazepine is not the first drug of choice. Always go for an antipsychotic and address the confusion with the antipsychotic and combine it with the benzodiazepine. Okay, so lorazepam can be given to calm him down. You can use oral, IV, sub-Q, or sublingual, be it any mode. You can start off with a low dose at 0.5 or give even 2 milligram every 6 to 8 hourly. Midazolam is also another option for us. Again, it can be given as a continuous infusion. Sometimes we have to even deal with terminal delirium. And in terminal delirium, the patient is very agitated. There is a lot of pain. Again, look for any correctable causes. Even if it is a terminal phase, there may be a impacted fecal mass, or there could be even a bladder retention. Physical examination is very important at even this point of time, and accordingly treat the cause, and also drug management with drugs like haloperidol, midazolam, and sometimes even continuous subcutaneous infusions can be given at the prescribed doses. So now coming back to Ramu, I'm just going to go through it again. He has multiple comorbidities, and now he's come with pneumonia, and he's drowsy, he's disoriented. Now, what are your thoughts on this? What could be the reason?
He could be delirious because of numerous factors. Like
correct. Numerous. That's a very good thing that you have said, that it's not just one point in your mind. It's like so many things could be there. That's just the right way to start. Okay.
What could be that because he's having features of pneumonia, it could be because of ventilatory. It could be acidosis, infection. Or
correct.
It could be infections. It could be and like metabolic derangements.
Correct.
Because he has type 2 diabetes, it could be
correct.
Some nephropathy related uremic encephalopathy.
Yeah. Correct.
And his age is all age, so that could be also another.
Yeah, he's very vulnerable for any kind of delirium. That itself could be a risk factor. Yeah. Any drugs that is going through your mind?
Drugs.
We have listed the different conditions, the clinical conditions. Now, we have the checklist in our mind. So any drugs that could be causing it? Well, he's diabetic. He's probably not eating much. He's he's probably still on OHAs or insulin. We don't know whether he's gone into hypoglycemia.
Yeah, hypoglycemia.
Yeah.
Yes.
And more. Amputed diabetic foot could also probably mean he is bedridden. Bedridden patients could also have issues like retention or bowel retention.
Bowel retention. Yeah.
Retention, right?
Yes.
Right. So we've already got the list working in our mind. So that's really wonderful. I think you have got some benefit out of the class, right?
Thank you.
Yeah. So with that, we have come to the end of today's discussion. And why don't we go on, move on to the presentation next? Thank you.
Thank you, ma'am.
Thank you, Vineetha. Thank you so much for the wonderful presentation. And as you said, they have answered everything. So that means it really worked well.
It's quite a relief.
Raju, are you presenting from there or?
Yes, ma'am. Dr. Sharina? Dr. Sharina, can you hear us, ma'am? Dr. Sharina, can you unmute and speak? Dr. Sharina, are you there?
We can see her name on the
She
screen.
has her phone setting problem. That's why. Yeah, she's trying. She's trying.
Okay.
Meanwhile, if you have any questions to Dr. Vineetha, you can ask now while she's trying to connect. I'm sure I know that you people may not be seeing much of delirium in your practice, but you might have seen it quite a lot when you were doing your undergraduate, because all hospitals will have invariably patients being tied up to the hospital bed, right?
Yeah, we have seen ICUs when we worked in the medical ICUs.
Dr. Sharina is trying.
Hello?
Yes, we can hear you, Sharina.
Yeah. Good afternoon. Sorry for keeping you waiting. There was an issue with my phone. Sorry.
No worries, ma'am. Ma'am, can you see the screen?
Yes, I can see.
Okay, ma'am, you can start your presentation, ma'am.
Okay. So good afternoon.
Raju, change to next slide.
The case is about Ramani. She is a 53-year-old female. She came to our department with CVA, left hemiplegia, left shoulder subluxation, CRPS, left hand, depression, diabetes and hypertension. Presenting, she had weakness for upper and lower limbs since 18 days. History of presenting illness. She was apparently normal while she was watching TV on the night when she suddenly developed weakness of her left upper limb and lower limb. There was a loss of consciousness. There is no history of any vomiting or seizures. She was taken to a local hospital, from where she was referred to a tertiary care center. She presented in the tertiary care hospital 4 hours after the onset of stroke. The CT was done. She was admitted in the ICU. There was some history of bleeding, so the thrombolysis was withheld. She in the medicine department, antiplatelet and statins were started. Bladder was catheterized. Riles tube was inserted. CT was taken, which revealed a large right MCA infarct with mass effect. So on 10th day of admission, she was referred to medical college. Financial constraint. At Medical College Hospital, she was admitted in the medicine ward. The antiplatelets and statins were continued. Riles tube feeding was given, and she was on CBD. Glycemic status and BP control was done. Supportive care was given, and patient was stabilized. After 1 week in medicine ward, she was referred to PMR department for further management. She was admitted here for rehabilitation. So past history, she is a known case of diabetic since 5 years, which was on irregular treatment, and she is a known case of hypertensive. That too, the treatment was irregular. Personal history, coming to bladder, she was on CBD. Bowel was continent, sleep was disturbed. Family history, her father has died due to stroke-related complication. Socioeconomic status, pre-omit occupation, she was a homemaker. Her husband has passed away. She had 2 sons, one is working and one is a student. Architectural history, its own Paka house, vehicle accessible, uneven terrain, pipe water supply, bathroom is inside the house with European style toilet. 1 step to enter the house, there is no internal barriers, the house has 2 rooms. Examination, vitals, pulse was 76 per minute, BP was 120 on 80, respiratory rate is 24 per minute, and she was febrile. Head to toe examination, she is moderately built, poorly nourished. She was under CBD and Ryle's tube, feeding was being given. CNS examination, higher mental function, it appears to be normal. She was conscious, oriented. Her speech was normal. She was attentive. She was normal in appearance and behavior. There was no delusions or hallucinations. She appeared depressed. There was frequent episode of crying, and there is she had decreased sleep and appetite also. Final diagnosis, she's a 53-year-old female with cerebrovascular accident, left hemiplegia, left shoulder subluxation, CRPS left hand, type 2 diabetes and hypertension. Her rehab issues is pain, depression, weakness, self-care activities, is dependent, bladder management, swallow assessment, then left-sided shoulder subluxation should be treated, left TA tightness was there, and her medical issues like hypertension and diabetes. Now goals of management, immediate goals is management of pain and prevent further complications. Short-term management, you have to first, as she's already having bed mobility, her sitting balance have to be trained, then moving on to wheelchair ambulation and bipedal ambulation, and also training for self-care activities. Long-term goal, she has to be given vocational training and recreational rehab. Significant investigation report. CT showed a large MCA infarct with mass effect. Treatment given. The ongoing medications like statins and the antiplatelet was continued. Oral antibiotics was given in view of UTI. Diet modifications was done. Stroke rehab programs was started where she was given physiotherapy and occupational therapy was given. So the AFO was given by the orthotist. Treatment summary, medical management include antiplatelet, statins, and antidepressant. That is fluoxetine was given to her. In physiotherapy, graded tilt-tabling was given. Then RIM exercise were given and sensory rehabilitation was done. OT included training in self-care activities, transfer training, sitting balance training, and for managing the CRPS, pain modulator, wrist block tents were given. For left shoulder subluxation, shoulder support was given and electrical stimulation was given to the deltoid. For left TA tightness, TA stretching was given and an AFO also was given. Then catheter weaning was done and RP was weaned off. Conditional discharge, her vitals was stable, general condition was good. Comorbidities like hypertension and diabetes was under control. Bowel and bladder was continent. She was taking few steps in the parallel bar with support. Her film score was 92. So her psychological aspect, she had 2 sons and she was doing all the household activities. So now she's worried about the education and job of her son because now she has to, she won't be able to do all the household works. Also, she was a religious person who used to go to the temple and all that also will be affected now. And she used to spend time with the friends, that is neighbors, by chatting and all. The medication which she was on were antiplatelet drugs, statins, antihypertensive, oral hypoglycemic agents, and pain modulators. The main concern in rehabilitation is who will care for her at home. Can she return to her activities? Will she be regular with her follow-up and financial issues in the family? Summary: 53-year-old female with CVA left hemiplegia, partially recovered, having multiple comorbidities, has achieved limited bipedal ambulation with orthosis with walking aids. So the main discussion points will be on whether she'll be able to have a proper follow-up, then providing care at home, barriers to return to her activities, then regain stability of the family. Thank you.
Thank you, Dr. Sharina. And Vineetha, we tried to bring in a case with delirium, but they generally don't see patients with delirium. So in their context, they see patients with neurological issues. So we had to incorporate this in today's session. Sorry for that inconvenience.
Yeah, Sharina, it was a very nice presentation. I was quite impressed with all the things that rehab can actually do to make a difference to this patient. She had presented with left hemiplegia and now she is able to actually take few steps. And I understand the catheter is also out and the Riles tube is also out, and she is able to at least partially become independent. Now we have some questions in front of us. Can I get to the next slide, Sharina? Yeah. So definitely home care has a big role over here. Continuing home care in terms of physiotherapy, and also in terms of she is also having some other clinical morbidities for which she has to be on a regular check of medications. So she has to be very prompt with that. There has to be a clinical supervision of things like that, and she's also on antiplatelets and things like that, which she has to be monitored if she is developing any bleeds or things like that. So care at home, I was also just wondering, is there any recommendations from your side as to how to change the environment inside the house so that to prevent falls or things like that? That was done from your side?
Yes, we usually ask them, like people with disabilities, we usually ask them to have anti-skid floor, and and we recommend having a high chair which makes them easy to get off and on from the chair. And if it is females, especially those who are doing cooking, we ask them to get the cooking surface and counter at the if she is not ambulant and she is on wheelchair, at the level of wheelchair where she can easily do her activities. And also we suggest having for some people, if they have a toilet which is only Indian type, we suggest having a commode chair or something which will help them to have an independent toileting.
Okay. Right, because it reminded me of a case, a patient that I had gone and seen at home care, a very elderly gentleman who he did not have any neurological deficit, but he was a bit demented. He did have some dementia, and we went to see him because he had sustained a fall. And luckily he didn't need sutures, but they were really bad bruises. And he was alone at home, and he was having severe peripheral neuropathy, for which was probably also one of the reasons for his fall. And some polypharmacy also. We were also suspecting that he had taken his antihypertensive twice that day, because we had recorded a low BP. So what we did actually was that we tried to assess his room, and we found that he had fallen on his way to the washroom. So we, our team tried to reorganize the room for them, move the cupboard which was there in the middle of the way from the bed to the washroom, and turn the bed in such a way that he could just get down and walk with help to the washroom. So I was just thinking of that when I saw that point.
Mhm.
Well, she does actually have barriers to return to job, and I think with the occupational therapist coming, uh, as a savior there, it is really going to motivate her to think further as to what she can do, even being at home. Until and unless she is able to move out from her home, until then she can do something to get herself occupied with. Her family stability in terms of economical, she could be associated with the palliative care team and checked on what benefits could be provided to the family. That is also there. But overall, I think this case definitely calls on for a multidisciplinary team, an equal hand of every component of the multidisciplinary team is very important, I think. It's a very nice case. Thank you for bringing this up, Sharina.
Thank you.
I have a question to the team in the PMR. So you were talking about modifications of the kitchen
Yes.
height and everything. Does that actually happen? Because if you tell me to change the height of this kitchen because I'm wheelchair bound, it takes a lot of effort from in terms of finances and in terms of construction, everything. It is literally modifying your home, and you might have actually drained out with all your money in the hospital, and the family members just want the person to be back at home so that they all can be back to the routine. So does that actually happen, the home modification, especially the things you
Yeah,
mentioned?
valid question really, because as ours is a government setup, we have the problem with financial constraints. We have a problem with the financial constraints. Sorry, please excuse me.
That's absolutely fine. We all have kids behind running around, no problem. Or anyone else in her team. Anyway, you all belong to one team, so anyone else can.
Yeah, am I audible?
Yes.
Yes.
As you told, there's a financial constraint is a big issue especially in our setup where most of our patients are very poor, mostly from the poor socioeconomical class. So but a bit of modification is always possible. Like they can get a high chair and commode chair and all. They can easily get. Maybe grab bar will not be that much accessible for most of them because making a modification to their home, most of them may not be following it. But again, the kitchen modification, we have seen some of the patient doing it, and they were very happy that they had the modification and they could do all their works on the wheelchair. So yeah, some of them are doing the modification as we have recommended, though some of them may be finding it difficult to have such modifications because of the financial constraints.
Thank you, Shireen. I just wanted to know about it because I always think myself in that position, then what would I do? Because there are a lot of things in the house that you need to change. We always think that we don't get all this, and we build houses like that.
Actually,
And yeah, tell me.
even if we don't have stroke, even now when we have an elderly people in our house also we are supposed to make some modifications to prevent fall. Like most of our bathrooms are having very nice tiles and also I think it's not the modification is not just for the disabled people, but as such in every house where there's elderly people, in view of fall prevention program, we have to advise regarding some sort of modification in the environment.
Yeah, true, definitely. I think all the constructions now have some mandatory guidelines that they should have wheelchair accessible lifts and all those things. In the big constructions, it is mandatory.
Yeah.
That's what I understand. So that is
Yeah,
one.
yeah.
And one thing I would like to add on to is that last session, Dr. Deepak was mentioning about the various schemes. So So all these patients, most of them will get some of the schemes from the government. Most of them are unaware of that, and they don't apply it for many years. And it will be nice if we can uh, just tell them about the schemes, like caregiver scheme, or patient who is bedridden, they have schemes, or elderly. There are plenty of schemes. So I
Yeah,
think that is one thing
yeah. In
you
our
might be
department,
already doing, right?
yeah, we have a social worker in our department. So she handles all such things like counseling them regarding the schemes and aiding them for that on all the certificates and all.
Is there any other thing that needs to be discussed? All of them belong to one team, so there won't be, all of them might have seen the patients, so they won't be having any uh, discussion among themselves. So if there are no other questions, I think we can wind up today's session. And thank you so much, Vineetha, for helping us in the last moment, as always. But thank you so much for the wonderful presentation and your time. Then we have sent the feedback link in the chat session. So your feedback is really important. Please do the feedback and then leave the session. Thank you so much.